Okay, so the presentation today is inspired by a few shifts that I've done where I've had to fly pediatric patients. And during this time, I found that I've had to make some sort of ethical decisions, which I've had to ponder over in the moment. And thankfully, I have quite a bit of insight into the Child Care Act and some of the laws pertaining to pediatrics in South Africa, which has really guided me in my decision-making process. And that inspired this presentation. So today is an ethical presentation, but I'm not going to spend time teaching you what an ethic and what a moral is and the four components of ethical decision-making, because by now I'm hoping everybody here should have an idea of that. What I'm going to do is jump in with a few case scenarios. Please, these cases are absolutely fictitious. I made them up in order to overcome or in order to present the ethical components that I wanted to present. And so they're not pointing to any situation, any scene or anything like that. I'm hoping that during the time that we go through these, I'm going to be asking some questions, and I'm really keen to hear your answers, your insights. So please type away. If you're not comfortable talking, type in the chat. I'm quite happy to answer the questions as we go, and each case is different, but each case will discuss quite a big ethical component that we're faced with South Africa, specific to medical, but it'll also bring in a few other things that we need to remember when dealing with our pediatric patients. So before we start, I just want to remind you that every single pediatric in South Africa has the right to take legal action against a medical person up until the age of 21. And I'll say that again, every pediatric in South Africa has the opportunity to take up medical or legal action against a medic up until they turn 21 years old. There is actually a case going on. It's been taken overseas at the moment where a child went through a hypoxic event at birth, and the child is now just turned 18 and is suing hospitals, practitioners, etc. So we should be at the beginning of all of these ethics things making the biggest word on the top of the page if you're making notes, and that's documentation. So through every single one of these, I want you to please remember in the back of your mind documentation. The more documentation you do, the better it would be if anything does ever go to court. And please keep a copy of it for yourself, because we all know documents get lost in the woodwork. So the first legal case, or the first ethical case we're going to talk about, I want you all to please imagine and that you're on a motor vehicle accident. So it's an accident scene. It's irrelevant what the scene is or how many cars. What you do have is a 5-year-old who's lying on the ground in front of you. The child is crying. The child says that they have a bit of a sore stomach, a sore abdomen. They're sort of clutching their abdomen. They're saying the pain's quite intense, and you are busy now. You've been allocated, or you are treating this child. The mother, who's not injured, so she's been part of the accident, she's not injured, she's well alert, she's speaking properly, and she walks up to you and she says to you, you may not transport the child to hospital. He's fine, and I don't want any unnecessary interference. Okay, so just that scene again is a 5-year-old child in front of you on the ground. The child is clutching their stomach, lots of pain. What is going on here from an ethical point of view? So again, I'm not here to talk about the medical treatment of a pediatric patient. The 3 ethical issues that we're going to discuss about this scenario, the first one, the question I say is, can a parent legally refuse care that might endanger their child? So can a parent legally refuse care that may endanger their child? That's the first question that I want you to think about. The second question is, based on, is it more harmful to allow the parent refusal or to override it? So is it more harmful to allow the parents to refuse or to override that decision and take the child? And the third question I'm going to ask is, does the paramedic have legal and ethical standing to declare it an emergency and transport the child against the parent's will? So all of the questions that we're going to be looking at in this particular scene is looking at what your rights are as, for those of you who are in the pre-hospital emergency field, what is your legal right on this scenario? where a mom is refusing for a child to be transported. So does anybody have any ideas? Maybe pop 2 or 3 words in the chat. Do you have the right? Don't you have the right? Can you take that child away from the parent? Where does your rights come in this particular scenario? Kobus, you're going to have to help me. For some reason, Teams is playing up today, and I cannot see the chat.
No worries, Debbie. Danielle Brown said
Yes.
you can override the parent.
Uh-huh. Anybody else say anything? Or is everyone being quiet and hoping Danielle got it right?
Richard said, I think as long as the consequences have been explained to the parent, then they can.
Okay.
Tibor says, I believe I can override the mother. So the general consensus seems to be to override the mom.
Okie dokie. So, if I had my slides, which I'm not too sure if you've had success yet, Kobus, but I'm going to actually be bringing in the laws as well through each of these. So if we have a look at the first ethical question, that's called legal refusal. Can a parent legally refuse care that may endanger the child? So the obvious answer to that is yes, any parent can legally refuse, but you can override. So Danielle, you got it absolutely correct. Under the Children's Act, number 38 of 2005, parents do have the right to consent to or refuse medical treatment for their child. So a parent, a legal parent, and please remember, I am using the word parent in the bigger scheme of the guardian of a child. So whoever's the legal guardian of that child, it could be a aunt, it could be a grandmother, whoever is the legal guardian of that child, in other words, the parent in that position, they do have the right to refuse medical treatment of their child. However, according to Section 129 of this Act, this right is limited. So it says, healthcare providers can override parental refusal when there is a risk to the child's life or the health. Now, going back to the scenario, you would have identified a form of possibly abdominal trauma. Does the child have a risk? Yes, they do. We all know that a children's organs are slightly bigger, and therefore in blunt force trauma, there is high risk of organ damage. Therefore, could be an emergency. Do we have the right? Is this life-saving? Absolutely, it is. So in emergencies, pre-hospital providers are permitted to act in the best interests of the child, even without consent of the parent. The Constitution of South Africa, it's under Section 28, actually supports this further by stating that a child's best interests are paramount in all decisions concerning them. So ethically, the situation touches on 2 key principles. We talk about beneficence, one of the 4 ethical decision-making processes. So beneficence is the duty to do good. And in this case, we need to ensure that the child gets timely care. Non-maleficence, another of the 4 ethical principles, is the duty to avoid harm. And in this case, delaying care in the face of potential internal injuries would be harmful. So both legally and ethically, the pre-hospital provider is supported in making the call during an emergency of removing a child from their parents' care and transporting them. Now, one of the guys who commented said we need to face the consequences. And if we think about the consequences here, it would be quite a big situation, because how traumatic would it be for the child to remove the child from the parent? And why is the mom refusing? And I always think to myself that the best decision that we need to make is often an educated decision. Now, let's just look at this hands down, bottom line, child needs care, child must be transported. There is absolutely no negotiation around that. But is there a moment to actually figure out what's going on? Because if we have the mom on our side, we have the child on our side, which because of a child's ability to give consent to his or her medical treatment actually helps us. I've got a few marks coming through, Kobus.
I'll check real quick.
So bottom line, we do need to transport this child, and that we are not negating on. But if we had the mom on our side, it would be a lot easier to actually do this process. So the question would be to figure out why this is going on. Why doesn't the mom want to be transported? Why doesn't the mom want the child to be transported? And many concerns of the mom may actually influence this decision, and often some of it may be financial, that they can't afford to pay for the ambulance, they can't afford to pay for the hospital. So these are sort of things that you can talk to the parent about. Again, no matter what the discussion is with the parent, the bottom line is your child is injured. I have to take your child to hospital. And the next step is, as a parent, you are legally obliged to give the best care to your child. By not transporting, you are negligent, and therefore I have to report you to social services. So if you see, this can actually become quite a negative thing, because now if the child is transported, you report the parent negligent, the child will probably end up in foster care. So the picture ends up perpetuating over and again, are all based on an ethical decision. The bottom line is, yes, you can remove that child, and yes, you can take that child to hospital. Just to quickly give you the laws, you've got the Child Care Act, where consent is required from a parent or a guardian for medical treatment unless the delay would result in serious harm. That's in the Child Care Act. That is further supported by the National Health Care Act 2003, which is Act 61. It is further supported by the Emergency Medical Services Act, which forms component of that National Health Act, as well as the HPCSA guidelines, which talks about duty to act in the best interests of the patient. So there is the first scenario. Does anyone have any comments or questions they'd like to discuss?
So Ashley mentioned in the chat, and she's asking if a mother can refuse care, stating that she will transport the child herself to her own practitioner.
So that's a very good question, and that often does happen. You need to make a clinical decision on this, and I think this would fall into your clinical guidelines, where you would have to do an on-scene discharge because of the child. So the child cannot refuse his own treatment, and therefore he cannot sign an RHT. The mother cannot sign on behalf of the child if the child is seriously injured. So the word seriously is something you would need to determine from a clinical examination. So if there's any indication that this is a serious condition needing hospitalization, you cannot do an on-scene discharge, and therefore the mother cannot transport the patient to their own practitioner. Okay. So there, how I would probably do this is I would fill out a patient report form. I would do a full medical examination, discussing this with the mom as I go along, and say, okay, this is what I found. I found the potential of an internal abdominal injury. I don't know, I don't have x-ray eyes. I can't see if there's bleeding internally, and therefore I have to transport it to hospital. So I hope that helps you. So yes, fall back on your clinical guidelines, the fact that you can't do an on-scene discharge for a critical patient.
Another question that was raised is, can a mother refuse care to a child stating religious reasons?
So that's also a very interesting question. The law states that no, you cannot withhold treatment that is life-saving. That's what the law states. We do have the consequence of different religions that come into play. So that would need to be escalated beyond you as a pre-hospital emergency care provider. This would end up needing to be an in-hospital decision made with multiple persons involved. I do know of certain religions that would withhold things for religious reasons, and there are constitutional rules that actually would pave the way forward for a child. So pre-hospitally, this is an easy one that there is no religion that withholds emergency medical care of a child whatsoever, because the law overcomes a religion which states you have to look after the child in an emergency situation and do the best for the child in the best interest of the child. Once in hospital procedures may be refused by parents because of religious reasons, and that would be a discussion with, it will go as high as the High Court or the Children's Court. So I hope that answers a question for you in the pre-hospital emergency situation.
Thank you, Debbie. Ben is asking, and I would also like to know, if a teacher or a caregiver, if they have the same rights as a guardian.
That man doesn't even
So-
look at me. You know what, man? I think that guy's in CCM. He's got Angel, Demo also. Yeah, flew with me, bro.
Somebody's
Flew
very
with-
sick in the background.
The water is coming out of his nose. He's standing with a cigarette. As he's talking, the water is coming out of it. He's just walking
Can
and
you mute
smoking.
that? There you go.
Yes, apologies. It just takes me a second to find.
To find the relevant person. Okay, Kubas, that's a very, very good question. So absolutely so there's something within the law called ad litem, which to all of us parents, we give, I don't know, it's when I put my heart on my arm, I suppose, it's when I hand my child over to the school or to another caregiver. By doing that, you are formally giving permission for that caregiver to provide the same treatment that you would be giving to your child. Or the expectation is there that they would be giving the same treatment to the child as you would. So, for example, if a caregiver was at the scene of this particular motor vehicle accident with the 5-year-old, the caregiver could say to you, I refuse transport, but the scenario would unfold exactly the same. The scenario would unfold that the child is an emergency, and therefore you as a pre-hospital person overrides that refusal of treatment because it's not in the best interest of the patient. Okay. Some of the ways to sort of overcome this is to say to the caregiver, please give the parent on the phone, and then you use choice words. Don't mince your words when it comes to children and when it comes to parents, because you have to make decisions quickly. It's very simple. Your child is injured, and I believe there may be a serious abdominal injury. I am transporting your child to hospital. The caregiver will be joining me because the child feels comfortable with the caregiver. You don't say, I'm thinking I would like to transport the patient. What, are you okay with that? No, don't give them the choice. It's very simple. It's serious. And if they say to you, you may not, say to them, according to law, I have to transport this patient. If I don't, I am negligent. I am going to this hospital. Please find me at this hospital. The parent can report you to the HPCSA. The parent can report you to the police. They go all the way. You are 100% supported. Just remember your documentation in remarks or in notes. Parent refused for me to transport this patient. I was not given a justifiable reason why, as this was deemed an emergency situation with a serious injury, the patient's P1, I acted in the best interest of the patient, and you are 100% protected. That's a very good question. Kobus, is there anything else?
Isaac says that sometimes they get refused to even assess the patients based on a scenario where a child is, for instance, covered in layers and layers of blankets. Is there any basis on which we can use to override the parent in such case to at least assess the child?
Yes, you can. It's just, again, fall back on the law and say to them that your child is presenting sick. Without medical care, you are acting negligently. I am here now. Let me have a look at your child so we can do the best for your child. Because again, if they don't allow you to do it, they're acting negligently. and no parent wants to be seen as negligent. And yes, there has been situations. Actually, if we've got time, I've got a case with a traditional healer where we can talk about some of the more traditional medicine challenges that are seen. But there has been cases where I've said to a parent, if you continue refusing me to assess your child, I am calling the police and I am going to lay a charge against you as a negligent parent. Simple. And that's all in the law. You are protected through the law with that.
Thank you, Debbie. Speaking of laws and acts, Theodore has a question for you about the acts and whether these acts are all fairly old. Are they still relevant? He's posing a scenario here where the mother or the father is a lawyer and now saying that these acts are old and no longer relevant. How long are these acts relevant?
Acts and laws are relevant until they are regulated and renewed. So irrelevant if the law was made and promulgated and gazetted in 1921 and has not been regulated with new regulations, it is still in play. There is no such thing as an old law. And what's interesting with child is the Child Care Act is the most recent law, which protects us even nicely. I'm actually going to go into that now. So you've got the Child Care Act was updated in, I think it was 2018 or 2019. So it's pretty recent. They can't throw that against you.
Thank you, Debbie. Ashley is asking if you maybe have some guidance for when the parent has a medical background, let's say, for instance, the parent is a GP, is there anything you would do differently to try and convince that parent?
Involve them. So involve them and say to them, if you palpate this patient's abdomen, you can see he's actually guarding. Therefore, that's telling me, I'm sure you know with your experience that a child who is guarding their abdomen is not normal. And therefore, I'm sure you know that the best thing to do is to transport. You see, it's all in the use of the words. So you put them in a position where they cannot disagree with you. Okay.
Thank you, Debbie. Richard, yes, Debbie.
Yeah, I was going to say, can I go on to, I don't know, because some of these questions are overlapping some of the other cases. Would it be ideal to go on to some of them, because we're going to be going into quite heavy discussions with the next case, which may answer some of the questions that some people have.
No problem. I'll just take notes of the questions and then we
Perfect.
can review them later on.
Awesome. All right. Okay. Now the next one is a scenario that came about from experience when I worked through Teddy Bear Clinic. And this one, I would like you to imagine a 10-year-old female patient. You're in the back of the ambulance and you are transporting this patient for an unrelated abdominal pain. So she's got diffuse abdominal pain. And while in transport, she very quietly tells you that somebody touched her private parts. The child begs you, who is the emergency care practitioner or provider, to please not tell anybody. So 10-year-old female patient, she's got abdominal pain. And while you're transporting her, she says to you, please don't tell anybody. What do you do? So the questions here that we're going to discuss is confidentiality versus mandatory reporting. What is the difference and when do we do each of them? We're going to look at justice, which is the third ethical principle, and we're going to look at protection. And we're going to look at psychological harm, particularly with a child. So what do? Child has reported that they've been touched inappropriately. They're 10 years old. What do we do? Kobus, is there anybody who is commenting through the chat? For some reason, I can't access the chat. Sorry.
No problem, Debbie. Brian is saying that the law requires us to disclose any suspected negligence or abuse.
Nice.
Estienne, you have your hand raised. Please, if you can unmute yourself and then go ahead.
Thank you, Kobus. Yeah, I just want to give a comment. I was in a similar situation myself, actually, where I was called to a scene for, I think it was an 11 or 12-year-old that was having seizures and it was unresponsive. When we arrived on scene, she was lying in a bed covered by blankets. And once we opened up the blankets to assess her, we actually noticed that she was not wearing any underwear. Her underwear was on her ankles. There was white fluids between her legs and her thighs. And we immediately covered her again. And luckily, one of the neighbors or family members was a police officer who just came off duty. I immediately asked him to come into the room and I took everybody else out. And I actually showed him and said, please take note of this. Please, would you join me in the ambulance and travel with me to hospital so we can hand this over to the hospital staff and actually get someone from the police station that's on duty to come and take over the case and try and preserve evidence. So what we did is we actually picked up the patient with the sheets, the beddings, everything as is on the stretcher, did our normal treatment, IV and all those things, monitoring, and tried to preserve as much evidence as possible, noted on our PRF the evidence we found, what steps we took to prevent it, and that we handed all of this information over to the receiving doctor. And we also noted down the constable, I believe he was constable's, his details and said he was present throughout. And this is his details, this is his force number to try and prevent and report something like this, because the child was not awake at that time. She was still post-ictal and wasn't able to communicate for us.
Yeah, not a nice one to have. Not a nice one to have experienced at all, and I'm sorry that you had to go through it. But I suppose, as emergency care providers, this is something that we're exposed to. So I will go through some things that I'll link your case to some thoughts within this case. And as you've just brought up, the situation is very common in the EMS. We are often the first trusted adult a child confides in. Often children confide in people in uniform, and we become one of those. Now, the Child Care Act, which is Section 110, makes it mandatory to report suspected abuse. So any form of abuse that you are privy to or you are witness to, you have to report. You have no choice in that. And we'll discuss where and how you report this. The Sexual Offence Act also further supports this duty to report sexual offences against minors. And please always remember that we're going to talk in the next scenario a little bit more about ages, but 10-year-old is still a child, so still considered a minor. Pre-hospital emergency providers are considered mandatory reporters. So you are by law, both legally and ethically obliged to report these incidences to a designated social worker or SAPS member as soon as reasonably possible. So ethically, this is really a complex space. The child has trusted you and asked you for your secrecy, but it also touches on the principle of confidentiality. And in this particular scenario, it is overridden by the duty to protect a minor. So therefore, that says we need to report it. Beneficence requires us to act in the best interest of the child, to prevent further harm and to ensure safety of the child. And by hiding this, we can't do that. Non-maleficence reminds us not to re-traumatize the child through our response. The way we speak, the way we react, and the way we follow up with this child matters and makes a huge difference in the progress of this case. Justice also plays a role. We must ensure fair access to protection, regardless of where the child comes from or who the alleged perpetrator may be. So in practice, how do we deal with this? Reassure the child that they were very brave to speak up and tell you what happened. Please remember that in some cases in South Africa, this may be considered for a child to be normal. A case I worked on many, many moons back involved children who lived in a very, very rural area within actually Africa, very rural. They only had themselves as the family. The mother passed away and the daughter took over the role of the mother in all aspects of life. The child did not know that this sexual acts with the father was not normal because she had nothing to base her normality on. There was no television and she did not go to school. It was only when she met up at another farm with another child and sort of brought this up did they realize it wasn't normal, and the mother of the other child reported it. So please, children don't know what's normal and not. They don't have anything to base a normality on. But when a child tells you body parts that they shouldn't know at a young age, you must be alert. A child should not be touched anywhere abnormally in a situation that makes them want to confide in you. So tell her gently that you do need to report it, but you're not doing it to harm the child. You're doing it to keep her safe. Ensure a calm, safe environment until handover. Remember, your documentation must be factual, it must be clear, and it must be to the point of what the child told you. Do not fabricate, do not add in, or do not add in anything you think. I thought it might be the XYZ because she looked at the child inappropriately. That's not up to you to decide. Your documentation goes to court and it gets thrown out so easily. These cases are so sensitive. So yes, you were very lucky to have a SAP member with you. Just remember the circumstance and the trauma of the child. They may not be comfortable having a policeman with them. So get the policeman to ride in the AMBO, get them to ride up front if that's what you choose. Any evidence that you have on scene, if you have a brown paper bag, that's the best place to put it in. But this needs to be handed over. So when you get to the hospital, who do you tell? You need to tell the doctor. You need to tell the nurse. You need to show them on your document that you have documented this as inappropriate and that they are signing for it. And you need to ask them for a social worker. You may not be there when the social worker gets there, but by documenting it with a doctor handing it over, you have, by law and by ethics, handed over the situation to an appropriate person. Okay. I would ensure that there is always a doctor to hand it over to. If you've only got a nursing sister or a junior nurse, please, you are then going to have to wait for a social worker, or you're going to have to take it to the SAPS, which makes it very difficult because many of the children who are in these circumstances do not have physical addresses. They don't have full names. They don't even have birth dates or IDs. So it is best to hand it over to someone within the hospital where they can gather the appropriate information from the child. So ensure that you have a clear report, a clear documentation, and I do recommend for your protection going forward that you keep a copy of this documentation. If this does go to court, you may be called in as the witness, as the first person who actually who the child told. Not an easy case at all, a rather challenging one. The next one is even more challenging, but does anyone have questions specific to this case?
Maybe there's a lot of mention in the chat for a Form 22. Is this our responsibility? What is it, and how does it work?
So Form 22 is actually through it gets lodged through the SAPS, and that does need to be completed and filled out, and it's reporting of I just need to get the name correct. It's reporting of abuse and negligent, I think it is. Deliberate negligent, that's the word I'm looking for. This form was designed from the Child Care, or through the Child Care Act and through the Department of Health. You can fill it in if you are reporting it to a police station. They will require you to fill it in, but a lot of the times the doctor will actually fill it in within the hospital. It is always ideal for you to do it because you are the first person that the child reported it to, and therefore you have first-hand information. So it is always the best thing to fill in if you can. And I always say in these cases, something that can just help you is always try and get a second person with you. In the case of gentlemen, and a female patient, it's always ideal to try and get another lady, even if it's a community member, to help you just for that child and just to protect the child. But yeah, you can absolutely fill out these forms. The only thing with this form is, as far as I recall, it does need to be stamped and submitted through the SAPS. So, and there is a time frame to it, which as far as I remember was 48 hours. So just discuss with the doctor when you get there. Sometimes you can fill out the initial report, especially if you haven't done an examination. Remember, re-traumatizing the child, unless something has happened to the child that requires emergency treatment, such as stop of bleeding or something like that, you don't really need to do too much of an examination. So therefore, the doctor would need to complete the rest of the form. Does that help, Cobus?
Yes, thank you. Thank you, Debbie. Do you know off by heart where one can get such a form?
Freely available off the internet. I will try and send you a form, Cobus. Maybe you can pop it into the chat.
Will do. Thank you, Debbie. Claude, your hand is up. Please go ahead.
Good morning, Debbie, and morning, Brian. I have a question. So this was sort of straightforward because you have ongoing abuse. So it makes it sort of straightforward that you need to override the privacy of what the child has told you, and then go and report it because there's something that the person is imminent threat. But now, what if the child, when you are alone in the ambulance and you're moving the patient and you say, why did you come to move to location X? And they say, no, previously, please don't tell anyone, but previously whoever that was living with us raped me, and that's why we moved away. How do you now, because there's no ongoing threat, do you still then report that? I mean, you still want to keep the confidentiality of the patient.
You still report it. It's according to the Child Care Act and according to the Sexual Offences Act, it is mandatory to report any form of suspected abuse. It doesn't give a date or a timeline.
Oh, okay, cool. Thank you for clearing that up.
Okay, so you have to, and that's why these cases are, I just want to give you a very, very simple scenario. That's why these cases are so technical. I live in a complex, and 2 houses up, there is a child that screams every now and then, but screams blue murder. And it's just this blood-curdling scream. And I thought to myself, oh, I'm going to have to go and report some form of abuse. So I took a toddler up there and I went and knocked on the mom's door and I sort of said, Mom, are you okay? Is everything all right? Only to find out she's got the most beautiful non-verbal autistic child, and that's his only way of communicating. And the mom looked at me and she says, I'm exhausted. I said, come and have coffee, and we spoke about it and it was great. So can you see how these cases can be, it is so technical and there is such a fine line. So yes, you do need to report suspected abuse. And if somebody said, I was raped, it needs to be reported. There's no negotiation there. Okay.
Cool. Thank you.
Okay, so some of the acts that protect us and protect the child in this one. Again, Child Care Act 38 of 2005. We've got the criminal law, which is the Sexual Offences and Related Matters Amended Act 2007. The Constitution, again, with the National Health Act. And for us, the Ethical Guidelines, Booklet 9 and Booklet 6, both of them guide us in confidentiality and when it may be breached. Booklet 9 talks about breaching confidentiality when disclosure is required by law. So again, the law stands in, we have to report these cases. Right, the next scenario is quite a technical scenario, and I think there's going to be quite a bit of conversation. So I'm going to jump to it, and then if there's any unanswered questions, we can go back and answer them pertaining to the other two cases. So this one, I want you to all imagine that you've responded to a school. It doesn't matter what the school is, it is a school, and an 11-year-old girl is found in the sick bay. She's complaining of severe abdominal pain, low abdominal pain. She's got some dizziness, she's got some nausea. And as you are assessing her, she says she is pregnant. She also shows signs of possible acute appendicitis. And she then, while you're prepping to get her to hospital, tells you she wants to have an abortion. So to go through that scenario, to give it back to you again, you've got an 11-year-old girl. You're at a school in a sick bay. The presentation of the child is medical with severe abdominal pain, low abdominal pain. You've got dizziness.
Okay.
She's got dizziness.
In the cover. I'm not going to steal my phone. I don't.
Sorry. She's got dizziness. She says she's pregnant. She shows signs of acute appendicitis. And just to top everything off, she tells you while she's in hospital, she wants to have an abortion. So where do you start with this? This is quite a technical case. So let's have a look at what we're going to look at. We're going to discuss when is a child not a child? We're going to have a look at ethical issues of child and classification of children. We're going to look at when a child can give a consent and when they can refuse refuse treatment. We're going to look at how to report sensitivity without re-traumatizing the case, and just in general, how to deal with this scenario. So, when is a child not a child? That's the first question I have. Kobus, I'm going to ask you to help me in the comments, see if anybody gets this one right. There are two cases of when a child is not a child. And while people are typing, we talk about a child is under the age of 18. That's according to the law. Under the age of 18, they named a minor. Over the age of 21, they're named an adult. So between 18 and 21, they don't quite know where to put them, but we are talking about anybody under the age of 18 being a child. So when is a child not a child?
Kim, you had your hand up. Do you want to give this a bash?
Sure. I was thinking that when the child has got sort of a full understanding, so they're over 12, so that they are allowed to give consent in terms of medical issues, but you can understand that they have got a full understanding of what's going on. So perhaps they're an older teenager, somewhere around there, maybe I would assume like 16, 17, 18. Well, 18, they're an adult, but I don't know. That's just what came to me now.
So it's a good guess. It is wrong. There is a few more legal things we need to add to your discussion or to your comment. So you got some of it right. So the first case when a child is not a child is something called when they become emancipated. So to put it simply, they divorce their parents. And this was brought into the Child Care Act because of the child-headed homes in South Africa. The child who's heading up the home could not do things like save money. He could not get payouts from the government because he couldn't get a bank account. So in came a law where this child can be emancipated from a parent. So he could then get a bank account, for example. He could actually be able to save some money. He could get his grants from the government. And this is a legal process. The child actually goes to court. He has, you said, where he's, what's the word? He's of sane mind. He's a little bit more mature in his thinking, and he can make decisions. And we all know that children, even though they're portrayed to be mature, sometimes they're still not. They're still babies. But the children had to be given the ability to look after their siblings. And we have to be cognizant of the fact that there are children-led homes in South Africa. So yes, it's usually, you are correct in saying that, Kim, the older child, because they can make a little bit more decisions. They can now get jobs, and they can actually bring in some money. So that's the first correct answer, is when they are emancipated by court from their parents. The second one is when a girl is pregnant. So this is scary. The minute you fall pregnant, you become a woman. A woman falls under a different act, a totally different act. And you are no longer considered, as long as you are talking about pregnancy, you are no longer considered a child. So a child, no matter what the age is, the minute they fall pregnant, as long as you are pertaining to the pregnancy, they are considered a woman. They are not considered a child. And that gives them the authority to make decisions based on their pregnancy only. So let's make this very, very complicated. Anyone under the age of 18, we know by law is a child. However, the law makes specific exceptions when it comes to medical decision-making, particularly around sexual and reproductive health. A pregnant child is still a child in legal terms, but in certain circumstances pertaining to their pregnancy, they are treated as a person with the capacity to make medical decisions independently. This includes decisions around contraception, pregnancy, and termination. The legal system acknowledges that while the individual is a child, they may have sufficient maturity and capacity to act independently in relation to their reproductive health. So according to the Choice on Termination of Pregnancy Act, any child, regardless of age, may request termination of pregnancy if they have the maturity to understand the procedure and the implication. This means, first of all, that this 11-year-old girl has the right to request an abortion without parental consent, provided that the healthcare team, and I use team in a bigger word, deems her capable of making this informed decision. The Child Care Act, or the Children's Act, also further protects her right to access healthcare services without consent of her parents in a confidential and supportive environment. So, taking it a step back, pertaining to this pregnancy, this child is not a child. She is considered a woman. I'm not using the word adult because in the pregnancy, they do not use the word adult, they use the word woman. She is complaining of severe low abdominal pain, dizziness, and nausea. If those symptoms pertain to her pregnancy, she has the right to make decisions based on her medical treatment because it's pertaining to the pregnancy. But she's also showing signs of acute appendicitis. Acute appendicitis is not pertaining to the pregnancy, so she needs her parents to consent if this needs surgery. She cannot consent for the removal of her appendix because it is not pertaining to her pregnancy. So very challenging in a pregnant child because you need to be able to separate the pregnancy with the other systems of the body. And I'll lay this out very clearly. If the baby, the child's baby, needs to have intrauterine surgery for some or other reason. And the medical team, which usually comprises of psychologists and psychiatrists and doctors, etc., they deem this 11-year-old competent to make a decision. This 11-year-old can give consent for her unborn baby to be operated on, but she cannot give consent for her appendix to be removed because it's not pertaining to the pregnancy. The minute she goes into labor and she needs a Caesar, she can consent to the Caesar to deliver the baby. It's pertaining to the pregnancy. The minute the baby is born, she is no longer a woman. She is a child. And therefore, any post-op treatment has to be signed by her parents because it's not pertaining to a pregnancy anymore. It's pertaining to a child. So pregnant children are very, very complicating. Now she says she wants an abortion. This child, if deemed able to make an informed decision by the medical team, can consent to her own abortion. She does not need her parents to sign for it because she has the right to make the decision on her own fertility and her own contraception, and the Termination of Pregnancy Act protects her because she is pregnant. So this is quite a challenging one, because if you're putting up an IV line on this child and it's pertaining to the pregnancy, she can consent. But if it's pertaining to the appendix, she cannot refuse. Very complicated, because she cannot say to you, she cannot give consent on how her appendix must play out. That her parents need to do. Now, just to take this one step further and make it even more complicated, according to law, this child had sexual intercourse under the legal age. So by law, this needs to be reported. Because on top of everything, she is now having, you've raised a flag for possibly a statutory rape or an underage sexual act. And that needs to be reported. So even if the child were to say that the sexual activity was consensual, the law views it as abuse because she is under the age of 12. Under the age of 12, she is not mature enough, and she does not have the mental capacity to make a decision about sex, and therefore she's underage. Between the ages of 12 and 16, she is physically mature enough, but not mentally mature enough to make the decision. And above the ages of 16, she is both physically and mentally capable to decide to have sex. So this child is not mentally or physically able to make the decision to have sex, and therefore this is deemed as a rape case. So on top of everything, it needs to be reported as well. So while the legal and ethical considerations are very complex in this case, the bigger picture is the child's immediate medical needs come first. She has got abdominal pain, she's got dizziness and nausea, and on top of that, she's pregnant. She needs to be transported urgently to a facility with the ability to manage both a pediatric emergency and a pediatric pregnancy complication. So you need to think about what hospital you're going to take her to. Emotional support, non-judgmental communication is essential during this time. While the Child Care Act recognizes the reality of child-headed households and allows for the designation of a child as the head of the home, these generically only include situations in where there is no available adult caregiver whatsoever, and the child is capable of leading a house, but the household should be supervised by a social service. So these are situations that make our decision-making very, very difficult, because what do we do and when do we do it? The bottom line in this scenario is the patient needs transport. Whether to you this is an appendix case or whether to you it's a pregnancy case with complications is irrelevant. it is a medical emergency that needs transportation, and you have the right to treat this child in any way that deems necessary to be in the best interests of her, and obviously within appropriate treatment. Okay, so if you would normally put up an IV line in this case, then that's what you would normally do. If you would normally give her something for the nausea, that's what you would do. You would do what you would normally do to any patient in this case. What changes in this case is your documentation becomes so much more complex, and your reporting structure becomes a lot more complex. Are there any questions?
So I think if I ever encounter this, I think I'm just going to give you a call. But Richard does have his hand raised. Richard, please go ahead.
Yeah, good morning. Can you hear me?
So just before you speak, Richard, I'm just going to change to the next slide. And that slide will give you, let me just, sorry, I'm just checking. No, no, I didn't put the laws on this one. Okay, sorry. Sorry, Richard, please carry on.
Yeah, good morning. Thank you very much for a very, very informative talk. Just a quick question regarding the 11-year-old. If the child is pregnant and she says that she wants to have an abortion, what does the law state? I might have missed it. Do the parents then need to be informed, or is she, according to law, able to have the abortion without her parents being informed?
Okay, so according to the Child Care Act and the Choice on Termination of Pregnancy Act, she is deemed a woman. And the minute you're deemed a woman, basically it's like saying you're an adult. She can make any decisions pertaining to her pregnancy. So anything relating to that pregnancy, she can make a decision on. So she can choose to have an abortion. She does not need her parents to sign and to give consent of the parent, to give the approval to have the abortion. But I'm going to put a big but there. Obviously, this takes quite a medical team to be part of this decision-making process. She will need to go through psychology and psychologists to make sure that she is mature to make an informed consent. And obviously, her parents, it is encouraged that her parents participate for the support that she's going to need through this process. Unfortunately, what often happens is that these cases happen where the young lady is raped, she is pregnant, because of cultural or religious beliefs, the parents don't want her to have an abortion, but she wants to because being 11, you can imagine what it's like. In that case, absolutely, she can make the decision and she can have it without her parents. I hope that helps you, Richard.
Yeah, it does. Thank you very much.
Thank you, Debbie. There's a question from Tulani in the chat, and Tulani is asking what would happen if a child were to come into hospital with these symptoms, only to find out in hospital that she is pregnant, and then she requests termination. And to add onto that, the child is not the main member of the medical aid. So Tulani is asking, what does the hospital do for this procedure, and what legal documents are required to give consent to this?
So the hospital would need to. Okay, so let me just understand correctly. Patient's been admitted with abdominal pain. While she's admitted, it's found out that she's pregnant. Correct. She now wants to have an abortion. She will then go through the normal process of being seen by the gynecologist, the obstetrician, as well as probably a psychologist or a psychiatrist to make sure that she can that she is of the right mind to make the decision. She will then sign the theatre form, which gives consent, and she will go to theatre.
And the medical aid complication, the child not being the main member?
The law is stronger than the medical aid. So she does not need parental consent to use her medical aid in this circumstance. Unfortunately, I think you and I'm talking legally, and I'm talking the perfect world. I think you and I know that there'll probably be there'll probably be a lot more happening here, but the medical aid will pay for the abortion if she has chosen to have the abortion and her parents cannot stop her and her parents cannot stop the medical aid paying.
Thank you, Debbie. Then just a last question on this case. One of our members is asking if a patient was to report to you, let's say during transport to hospital, her wishes to have an abortion, do you have an obligation to hand that over to hospital?
I would do that, and I would make sure it's in my documentation. I would just say to them that during my time with the patient, she did express having an abortion. So you may need to just please be cognizant of this decision. You may need to action the process. Remember that these cases are time sensitive because the abortion can only be done during certain time frames. So as I was saying earlier, it's often a rape case. They find out that they're pregnant late. I mean, there was a case I was involved in where a child had not even started menstruating yet, and she was actually pregnant. So she didn't even know she was pregnant until it was too late, and there was nothing they could do. So the more you are forward, excuse me, the more you are forward in telling the medical team of what you were told, the faster these processes can be put in place. And please, I'm not saying that to push her towards having the abortion, no, towards pushing her towards having the correct assessment by the correct team in order to make the correct informed diagnosis.
Thank you, Debbie. If I can just put one more in there, I think it's quite an interesting question. Johanna is asking, so she's painting the picture of a child who came to hospital and requested an abortion. And then during the procedure, there are complications. And she's asking now whether the surgical team will have to inform the parents of what procedure was, because now technically this is she's no longer pregnant, but now there's complications. Now,
yeah, but it's pertaining to the
parents,
abortion. Okay. Yeah, it's these cases are so challenging. And again, I remind you that I'm speaking from the picture perfect scenario. I'm speaking from what the law is telling us. There is so much more to it. You know, I just pray that any child that has to undergo an abortion does have her parents standing right next to her, because it's such a traumatic thing to go through. When you sign consent, your consent in hospital always will cover any emergency treatment that needs to be done if something goes wrong. So it's not like they're going to have to run out and tell the parent that, sorry, there's been a complication, we're going to have to do X, Y, Z. It will have already been covered. But, you know, the chances of a child losing her uterus during an abortion is high. What do you now tell an 11-year-old? You don't have a uterus anymore. To her, what does it mean? So I really pray that these cases are done with parents, but you're breaching ethical and confidentiality boundaries when you start bringing them in, because why was she there in the first place? You with me? The hospitals work very, very closely with social workers. They work very closely with the courts. So in a case like that, you would have social workers and courts coming in to protect the medical team from breach of confidentiality.
Thank you, Debbie. That was the last question pertaining to this case.
Okay. Cobus, I do know that we had a time of an hour. I have one more case. If people want to stay and listen, would you like me to carry on? I'm comfortable to do it. If people want to stay on, they're more than welcome to. If they don't want to stay on, I don't know if you want to give them the word for the day or whatever, and they can leave. How do you want to handle it, Cobus?
I think we can post the register and the word of the day, and then we can carry on with the last case, if that's okay with you.
Perfect. Okay, so the word of the day for today is decisions. I'll just ask someone to type that or to post it. So that's just decisions, like decision making. And I'm going to go on to the last case. So you're called out to a rural homestead or a rural area. You've got a 4-year-old child, and this child's having an active seizure. So you physically see the child having the seizure. It's reported that this one has lasted more than 5 minutes. The crew finds the child semi-conscious with a very high fever. A traditional healer is on the scene and they're insisting that the convulsions is due to an ancestral disturbance and that hospitalization is not necessary. He's actively or she is actively applying herbs or rituals and instructs the crew not to interfere with the process. The parents are silent, they are there, and they defer to the healer because he's the respected figure in the community. I think that this case is a common case. We experience this in South Africa, and I'm sure each and every one of you have experienced something similar. So the questions that we're going to look at cultural respect versus clinical responsibility. We're going to look at, again, consent in emergencies. And the last thing that we'll just touch on is community trust and long-term relationships. So what do we do here? We have a challenge in our minds between cultural respect and clinical responsibility. And I think that when I looked at this case, I applied myself to it and I thought to myself, when I am ill, I don't go to a traditional healer first. I go to my doctor. Yet a traditional healer for many is a doctor. The traditional healer is seen as the doctor, especially in our rural areas where doctors are not available. The traditional healer takes over that role and is a very, very important component of the community. They are often one of the most respected community members, and they play a very, very important role. So how can we, as pre-hospital emergency providers, how can we respect the cultural belief without compromising urgent medical care? And we turn towards the Constitution for guidance in this one, where the Constitution protects cultural and religious practices only if they do not infringe on the rights. Then you take it one step further and you look at the Child Care Act, which talks about valuing culture, but prioritizes best interests of the child. We look at the HPCSA. The guidelines stress cultural sensitivity, but they always put patient safety first. So how do we do this? Because we do respect the fact that in some cultures, they do believe that seizures are caused by ancestral disturbances, and it is a very hard place to try and convince those who believe that so strongly otherwise. But at the same time, we need to look at this child and we need to recognize that this is now becoming a prolonged seizure and we need to do something before there is damage to the child's brain. So, Kobus, I'm hoping people are typing while I chat. How do we deal with this? What do we do? Who supersedes who? And how could we imagine this scenario to play out in the best interest of the child whilst not breaching a long-term relationship and community trust possibly that's been built? Is there anything in the comments? Hi.
Can I perhaps just add a comment there?
Yes.
I had a case in a while ago, a few years ago at a high school. We were called in there for a young 16-year-old girl that was having seizures, and the teachers were a bit panicky. They didn't know what to do. Anyway, when we got there, luckily they had a sick bay, and we got the medical history, as in, she didn't really want to communicate with us. The child, she was actually but very anxious, hysterical. And so what I did, I called in the class teacher and I closed the door, and nice and calmly. I just got a background of who's a best friend and all of that, because sometimes you tend to find out that these kids don't confide in anyone. And long story short, then the best friend came in, closed the door again, and then she explained to us that the child is busy with cultural and traditional healing at that age, okay? And so clinically, we checked all of vitals. We did the AGT, the blood pressure, everything. We assessed her from head to toe. There was all of vital signs was fine, but it was just this erratic behavior that we couldn't understand. But then they found the father, and I spoke to him over the telephone, and he did confirm that she was busy with being trained as a sangoma, because the child was apparently blessed, and she had, she was a candidate for that type of thing. At the end of the day, I myself and my partner consulted with our control room as well, and everyone decided to rather wait for the parent. And the parent came, and we explained the situation, and he agreed, and we accompanied them to the hospital at the end of the day. But things like this, I agree, we have to firstly look at the entire holistic situation, apply our skills in terms of clinical intervention, but also respectfully, also deal with that part of, especially when it comes to the cultural side of things. But yeah, thank you.
Thank you very much, and that's very, very true. It's a very challenging one, because there's a lot of crossover between traditional medicine and modern medicine. So how are we going to deal with this situation is you once you've made the decision, once you are there as a medical practitioner, you need to remember that you are there as a medical or an emergency care provider. You are there to provide emergency care. So the more you the more you play to the traditional healer, the less your sense of urgency becomes. I'm hoping I make sense when I say that. So you are there in the capacity of an employed person. You're working as an emergency, you're on shift as an emergency care provider. So you need to arrive there as an emergency care person who's going to potentially transport this child. The problem with this case is now you are, as I said earlier, breaching a potential community trust and a long-term relationship. So nice way to do this is to explain the danger of the seizure, especially the prolonged seizure, and just say, if you don't stop the seizure, the brain of the child loses oxygen, and if we lose oxygen, the damage can occur. Acknowledge the healer's role. The healer can use as many herbs as he likes, as many rituals as he likes, while you are busy working. So say to him, let's work together. Let's try and conquer this together. We're safe. As I said, we're safe. Allow those harmless rituals to proceed. Obviously, you want to try and prevent anything from being administered to your patient at the time. Consent in the emergency. Can a paramedic treat the child without the parental or the healer consent? We've covered this already, and the absolute answer is yes. Emergency care must be given. Now, remember that the traditional healers are actually being recognized in the medical world, but there are many of their scope per se, the medication that they're administering is not according to the Health Professions Council of South Africa, and therefore you are absolutely in right to remove that child, because according to Health Professions Council, they're administering a drug that they are not legally allowed to, and therefore they can be deemed as negligence. So it's a very, very technical world to be in this scenario, and it's very, very challenging. What you do need to do is you do need to initiate emergency treatment immediately and stop that seizure as quickly as possible. If possible, have a witness, document any attempts to explain and gain cooperation from the people that are there, for example, the healer, but do not delay care if the child's condition is deteriorating, because if that child does die, you will be found negligent. You are there, you were sent to the call through the call center to treat this child, and if you don't treat, you are negligent as an act of omission. Unfortunately, how do you protect? Well, this is how do you protect the child while minimizing damage to the community relationship, which is a big, big challenge. We can look towards a principle of Batepele, where we need to deliver services with dignity, consultation, and respect. And that is across the board for anybody who's in any form of service. Batepele is not purely just a medical principle, but it's a principle across the board. Use non-confrontational language. Do try and show respect. You may not have respect shown to you, but we are, at the end of the day, representing the HPCSA, and we do need to show respect. Where possible, allow the healer to accompany the child. It's really, or to observe your care. I do recall many years back working in Berea and Joburg. I used to work very closely with a traditional healer. And many times a traditional healer came in the ambulance with me and carried on with their harmless ritual. It was harmless to the child at the time, but really important to the community and to the family members. They may not be seeing the seizure as a fever-induced seizure. They may be seeing it as ancestral. And as much as it's difficult for someone who's not au fait with the traditional healing world, we do need to respect their role within healthcare within South Africa. You may need to involve elders to mediate, especially if there are community elders, but also remember that your role in the community, your role in engaging the community with education and reflection can preserve your EMS credibility. So if this is a norm within the community you work, I am hoping that you have gone into that community and met with the healers and met with the elders and discussed scenarios where you can work together in order to provide best interests for your child. So yes, National Healthcare Act, your Child's Act, and the Constitution is what would protect you should you remove this child against everybody's wishes. Those are the 4 cases I have for today. If anybody has any questions, Kobus, you'll have to screen them for me, but I'm happy to answer or assist on any of the cases.
Thank you, Debbie. There's just 1 or 2 questions we haven't quite covered yet. Just give me a second to read over them.
I've actually managed to get them. I see Danielle has written here, delicate legal boundaries. Obviously, it would be great if we had extended information regarding the subject and possibly including other types of abuse for future. So 100% we can put together more presentations for you, Danielle. You're quite welcome for anybody. Kobus, you can put my email address in the chat. People can email me, but they're quite happy to help anybody out. I see Brian has popped in the chat a link to the Child Care Act, as well as to that Form 22, so it should be there. I would acknowledge the role of the traditional doctor and explain my need to take over. That's written so nicely, acknowledging their role. And we do need to acknowledge the traditional healers' role in South Africa. They play a vital role in areas where medical is lacking. So yes, that's a very good answer. I don't see any other questions.
Julene did ask earlier, if SAPS is on scene, could we ask them for assistance in these types of cases, and what would that assistance look like?
So yes, SAPS. I remember when I first started in the EMS, any mental case is a SAPS case. Nowadays, anything is our cases. They don't like being involved in it. So normally what I do is I normally have a game plan where I would discuss with them. And again, it's all in the use of the words. So I would say to them that I have a critical child who is having convulsions and the family are refusing for me to transport the patient. If I do not intervene and stop the convulsions, there is a high risk of brain damage to the child. I would like them to be present with me while I remove the child, place the child in the ambulance and leave the scene. And if they could please make sure that the scene remains safe for me and the child. And they will normally do that. They don't want to pick the child up. They don't want to move the child. They don't want to be involved in that. So if you tell them to protect you and the child, they're usually very good with that.
Thank you, Debbie. Uriel asked also a little bit earlier, specifically related to mental health care in children. Are there any acts that speak specifically to mental health care for children?
It's such a difficult one because that brings in a whole new world. So again, I think without going deep into this, because it depends on the capacity of the child and it depends on the diagnosis, the treatment, all of that sort of thing. But at the end of the day, if you're asking about how do we treat the child with a mental problem, you always need to remember, act in the best interests of the child.
Thank you,
Does
Debbie.
that,
And then the
does that
last
answer
question.
it?
Yes, I think it's a good blanket answer. I don't know of a specific act that speaks specifically of mental health in children. Not that I am the knowledge hub on this.
No.
And then
Yeah.
lastly, Devold asked a question, with the involvement of social workers, is it necessary to involve them at the scene? Will it negatively impact the case if they are not on scene?
What would negatively impact the scenario is if you delayed time to wait for a social worker. Social workers, especially in our rural areas, well, social workers in general are few and far between. So by waiting on scene, it would negatively impact the child. Your role and responsibility would be to document what you saw and what you heard. That would be the best case for the child. If you do pick up a scenario where there has been rape and it has been recent, don't fiddle with anything, don't touch anything. If there are loose pieces of clothing, into a paper bag, please. Paper bag is the best, because a plastic bag harbors moisture, and that then skews the results of any testing. And transport the child immediately. Then you would need to document things like, and I'll go back to the case a little bit earlier where the gentleman said, I found the child lying on a bed. She was lying on her back. When I opened the covers, I noticed her underwear, and you need to be specific. So her panties were lying around her ankles. And you're giving an actual, you're trying to put somebody else into the scene using your words in your description. Even if you have to add an extra page onto your patient report form, please do that. Make it as descriptive as possible, but only what you see and only what you hear. Don't add anything else in. Times are very, very important. So make clear and accurate loggings of your times. So when things happened, what time she told you, what words she used, it becomes very important. And then obviously when you get to hospital, if the social worker isn't there, the doctors will call in a social worker. But very difficult to get a social worker on scene.
Thank you, Debbie. Erin just made a comment to say, if you are working in an area with more traditional beliefs, it would be beneficial to introduce yourself to the traditional healers, and I completely agree.
Absolutely.
Melissa, your hand is up. Please go ahead.
Hi, yes, thanks, Debbie. Thanks, Kobus. Just a quick one, and it's a bit of a different scenario, but in the event where we are seeing patients that have suffered from sort of toxins that have, adverse events and side effects from toxins that have been ingested, do we have any sort of obligation there outside of the normal clinical sort of treatment that we would do?
Melissa, if am I understanding you correctly, and as far as reporting is concerned?
Yes, that's correct.
Okay, so if there's any, again, the word suspicion of forced ingestion, that needs to be reported. And it's interesting. Somebody sort of just said this to me, and it was the craziest light bulb moment. No child willingly drinks a cup of paraffin because it tastes disgusting. So if there is absolute indication of abuse where the child has been forced, then yes, that does need to be reported. But then again, I mean, how many times have we had to force a spoon of paracetamol down a child's throat because they need it? So when I answer that, I answer it within reason. It's very challenging because of traditional medication. We don't know what's on board, and children are presenting in so many different ways. I had a case the other day with a kid in renal and hepatic failure because of something that they had ingested. So I think the best bet would be to document as much as possible, and would be to escalate it when you get to hospital, to just say that there's an unknown substance on board, and I have a high index of suspicion that this child was forced to take it.
Thanks, Debbie. Yeah, I'm specifically asking because there is an area where we see this quite a bit, and it, if it's such a recurring issue, and again, it's difficult because I think most of the time it is a suspicion, and so there's no sort of solid evidence in terms of what's actually happened and what's, because often when we get to them, they've already been hospitalized and we're just transferring. And that complicates matters even more. But it specifically speaks to, the traditional healers and what's actually been given to them. And when there's a point where really there's nothing else that can be found, and the suspicion is then that there was some sort of herbal intoxication. I think just that line in terms of what do we do then?
Just document that. Just document that. I think it's so difficult because, like I said to you, how many times have you had to force a spoon of paracetamol down a child's throat? And is that any different from a rural scenario where you're forcing a spoon of traditional medicine down a child's throat? Both drugs are given in the best interest of the child. Both drugs are given in order to help the child in that moment. So is that actually forcing? Do you get what I'm saying when I try and explain it that way? And I remember my child hated Panado, and yet when he had a high fever, that's what you would give. But if you had a child who was forced because they've now shoved half a cup of paraffin down his throat, then I would start to worry. I just always worry about the word forced when it comes to the likes of giving that child. You would have to be careful on how you documented that.
Perfect. Thank you so much, Debbie. That's very useful.
Pleasure, Melissa. Pleasure.
I think we have time for 2 more questions, and then we can go to closing thoughts. Ben asked in the chat if we can take any photographic evidence to help record what we found on scene. Is that overstepping? Would you recommend?
You can do that. You've got to be very careful because the law states that if that photo got onto social media and that case ended up in court and they found that photo on social media, that case would be thrown out of court. So be very, very careful on how you are using your photographic evidence. I often take a photo of an MVA and I take it to the doctor and I say to the doctor, this is the scene that we were looking at. And then the photo is deleted off my phone. I don't post it out. I don't save it. It gets deleted. Recently, I had to take photos of x-rays to give to a doctor, and the doctor took photos off my phone because there were no x-rays available. That is absolutely appropriate. You've got to just be very careful of, again, how you're using it. If you choose to print those photos, attach them to your patient report form that you are keeping personally, or that you are submitting in as a legal document, then that's fine. But please don't send them to friends, family, etc., or put them into a shared folder or something like that. POPI Act is very, very strict with us. we are doing this within the protection. And if you are handing it over, I would document there that photos were taken on scene to show the doctor or to show SAPS or something like that.
Thank you, Debbie. David, your hand is up. Please go ahead.
Thank you. Good morning, all. Just coming back to, damn, you know me, my memory. Coming back to when you get to a scene, it's not. That's where I wanted to start. Sorry. The two things I always remember is to do no further harm, and also to do what's best in interest of the child at all times. The question was, when do you get social services? That was the question that I was trying to attend to. Now, there's two scenarios that play out. So it could be an after the fact that you've transported the patient, you reported it to the doctor, they will bring in the social services and they will deal with it. If you're sitting with a situation on scene where it's not the only child that you can see that is physically being neglected or abused, or the living conditions that they are living in, that type of thing, you're going to have to get SAPS and social services on board, because it's not only the patient that you're treating, but his siblings as well, or her siblings as well, that might be in a similar situation just at an earlier stage. So that's when I would definitely get hold of SAPS, and I would maybe call up some backup from my supervisors and get welfare services or child services into that space. Because when I leave the scene, I'm actually now neglecting the rest of the patients or the rest of the family unit. And the other thing I wanted to also press hard on, you were talking about, when you're looking at a 12-year-old now being a woman, being pregnant, or you're sitting with any female patient with trauma, whatever, it's always best to have somebody accompany you, that you are not drawn into later allegations of harming the child, if you understand what I mean. I've heard of a school principal who was dismissed for picking up a young girl, and apparently somebody took a video and it looked inappropriate, she was trying to get her to the sick bay. So his Samaritan help, his good help, turned out against his favor, and he was actually fired. And I always think about that is so unfair, because you always we always end up trying to help the child and not anyone else, because that's our focal point. But that's just some comments I wanted to make. Thanks a lot.
Absolutely, and social media it's horrible. It really is. But I think a very good colleague of mine once, she always used to teach, Kim Williams. She always used to teach medical law and ethics, and she always used to say, "Imagine your act as the headlines of the newspaper. Would it sound like you're a hero, or would it sound like you're a villain?" And that's something I've always remembered to this day, is if I'm not too sure whether this is ethically correct or not correct, if I did it, would I be a hero or would I be a villain? And if I'm a villain, I don't want to do it. And the other thing I just want to say, and to everybody sitting on this call who's from Dispatch, I'm sorry, I'm about to put the load on you, but you're our best friends in this situation. Everything through a recorded line. So don't phone the SAPS directly. Go through your call center. Get these calls on recorded lines. It all becomes part of the evidence chain. And the gentleman who just spoke now, it's very simple. I've got a priority patient I need to transport, but I'm really worried about his siblings, this home. There's a lot of negligence here. Could you please get out a social worker to please review this area, because I need to transport this patient on a recorded line, and you're absolutely within the ambit of your profession. So it's a very good point. Thank you very much. Thank you, Kobus.
Only a pleasure. Debbie, if you're up for it, there's one more hand.
Yeah.
Richard, please go ahead, and then after Richard, we can go to closing remarks.
Yeah, morning once again. Just regarding photographs and evidence and that type of thing, I I don't know if Debbie, you're able to answer this question, or maybe this can be for another discussion. But I once was at quite a horrific accident where unfortunately a child was killed, and the father was intoxicated. But I would just like to know where the law stands, and where do we stand actually when it comes to the law with people taking photographs and posting, or what can we do, or are our hands pretty tied?
Very good question. Our hands are pretty tied. We don't really have the ambit. Most MVAs happen on public property, public property, and therefore it's very challenging to stop the media taking photos. How I normally do it is, if I see photographs, I normally say, please, you may not take any photographs of me. And then I make sure I stay as close to the patient's face as possible, because then inadvertently I'm protecting the patient's face. I also, now we are protected by the POPI Act. So you can say, according to the POPI Act, you're not allowed to take photos of anybody's face. If you want to take a photo of the car, they must do that. SAPS is your best friend here. And I've had to say to SAPS, please confiscate a camera. But it's very challenging. The other problem is you're so busy treating the patient, you don't actually have the time to focus on who's taking photos of what. So I normally just make a general announcement, please don't take any photos of me, according to the POPI Act. And then you stay as close to the patient as possible and protect them that way. I hope that helps. Okay, so I'm hoping that Kobus has popped up the last slide. I've got 5 key home takes. You can read through them yourself. We've spoken the whole time saying that the child's best interests come first. We have to, according to law and ethics, prioritize the child's right to life, no matter what. That always comes first. We are legally empowered to act in emergencies. Just cite the Child Care Act, cite the National Health Care Act, and that will usually give you sufficient room to actually protect that child. Reporting is non-negotiable. Any suspicion of abuse, neglect, or exploitation must be reported, even if the family or the child objects. You have to do it. Again, I'm not saying run out there and report everything, but please, if you do have a suspicion, you need to report it, because if you don't, you are found as negligent. We need to respect our community dynamics. We don't want to compromise care. So our childs do come first. So if you're in a community that does use a lot of traditional medicine, go and find the healers, go find the elders, go and have a meeting, go and get to know them, see how you can make this work, instead of having that clash. And then children actually have more rights than assumed. These pregnant minors, mature children, child-headed households, they can exercise rights. And we have to trust that. We have to trust in that moment. So if a child says, I am of a child-headed home, I have the right to do this, we have to actually trust within that moment. Remember to document everything, document what you see, what you hear, don't make anything up, and keep those documents for up until that child turns 21. It will help you, especially nowadays with the laws becoming more and more prevalent and protecting the children. Know your laws, know your ethical decisions in complex cases, and if you don't, reach out. There's always someone out there to help you. I hope you enjoyed today's lecture or chat or coffee and case, and to everybody who participated and to those who just listened, thank you very much. I hope you have a great Thursday.
Thank you so much, Debbie. I, for one, definitely appreciated your presentation and learned a lot. So thank you all for attending. I will just display the link for the register. If you haven't completed already, please follow that link. And then the word of the day will be decisions. Thank you again, Debbie, and thank you for Stat Medical for sponsoring today's Coffee and Cases.